Hello. Today we have the lecture number 7, and topic is environmental lung diseases: asbestosis, silicosis, coal worker etiology, pathogenesis, clinical features, diagnosis, and treatment. And also interstitial lung diseases: etiology, pathogenesis, clinical features, diagnosis, and treatment. First, asbestosis. Type of pneumoconiosis caused by inhalation of asbestosis fibers. Risk factors are occupations involving the manufacture or demolition of ships, plumbing, roofing, insulation, heat-resistant clothing, and brake lining. Also, smoking. Pathogenesis: inhalation of airborne asbestos fibers into alveoli causes asbestosis. Inflammation and fibrosis of pleural parenchyma causes risk of carcinogenic effects. First of all, bronchogenic carcinoma, most common malignant complication, and mesothelioma. The clinical features are long latent period, exertional dyspnea, dry cough, which continues in productive cough, digital clubbing, bilateral fine, basal, and inspiratory rales. About diagnostic. First of all, imaging, chest X-ray, diffuse bilateral infiltrates predominantly in the lower lobes. Interstitial fibrosis, supradiaphragmatic and pleural reticulonodular opacities. Plaques, initially mostly linear infiltrates are seen. Eventually calcified, ivory white or non-calcified plaques appear. Rounded atelectasis, in some cases pleural effusion. Radiographs are classified by the extent of radiographic abnormalities according to the WHO International Labour Office classification. High-resolution CT scan. Parenchymal fibrosis, especially basilar, peribronchiolar, and septal. Pleural plaques and pleural reticulonodular opacities. Supradiaphragmatic opacities, plaques, subpleural linear opacities. Also, we need pulmonary function test. Restrictive ventilatory defects, decreased pulmonary compliance, early decreased DLCO, later reduced vital capacity and total lung capacity, normal to increased ratio of FE1 to FBC. Then we should obtain bronchoalveolar lavage, and we have microscopic asbestos bodies in this lavage. Occasionally found in alveolar sputum samples, stain positive with Prussian blue, and appear as ferruginous bodies, dumbbell-shaped and golden brown fusiform rounds, surrounded by an iron protein coat. And at last, biopsy. We must obtain the biopsy. And in biopsy, we have microscopic asbestos bodies and fibrosis. No curative treatments exist for asbestosis. Management includes the following measures: cessation of exposure, oxygen therapy, immunization against influenza and pneumococcal pneumonia, antimicrobial treatment of respiratory infections, and palliative care in the case of advanced diseases. Now about silicosis. Etiology: inhalation of crystalline silica, most commonly as dust. High-risk occupations for the development of silicosis include sandblasting, mining, for example, coal mining, construction, for example, tunnel construction, hydraulic fracturing, ceramics production, quarrying, glass manufacturing, and working in foundries. Pathogenesis is inhalation of silica dust, then we have deposition in the airways, then interaction of crystalline silica surfaces with aqueous media produces oxygen radicals. Then inflammatory reaction and injury to pulmonary cells, for example, alveolar macrophages. And last, pulmonary fibrosis and scarring. The clinical features are acute silicosis refers to a short-term exposure to a large amount of crystalline silica dust. Within days to weeks, dyspnea, cough, pleuritic pain, fever. Within months to a year, weight loss, fatigue, cyanosis, respiratory failure. Chronic silicosis refers to long-term exposure to crystalline silica dust. Patients may remain completely asymptomatic or develop symptoms only after several decades of exposure, such as chronic cough, often with sputum, and exertional dyspnea. Fatigue and weight loss, signs of respiratory failure, and cor pulmonale. Kaplan syndrome, pneumoconiosis in combination with rheumatoid arthritis, characterized by rapid development of basilar nodules and mild obstruction of ventilation. Now, diagnosis of silicosis based on the occupational history, respiratory symptoms, and the following diagnostic investigations. First of all, chest X-ray, which shows eggshell calcification, well-defined cycle-shaped calcification of the rims of the hilar lymph nodes. Bilateral diffuse ground glass opacities, large number of rounded, solitary, small, less than 1 centimeter in diameter opacities, particularly in the upper lobe of the lungs. Confluence of solitary lesions from opacities that gradually enlarge to more than 1 centimeter. Lung function test, FEV, decreased TLC, FEV1, and FEVC ratio, all of them are decreased. Then we have findings indicate a mix of restrictive and obstructive lung disease with pulse oximetry and arterial blood gas, reduced oxygen saturation. Biopsy of the lung shows silicotic nodules characterized by weakly birefringent silica particles in a central hyalinized region surrounded by concentric onion skin collagen fibers. How we can treat silicosis? There is no definitive treatment for either acute or chronic silicosis. Avoid further exposure to crystalline silica. We should. Lung transplantation in patients with advanced respiratory failure. And symptomatic treatment like smoking cessation, bronchodilators, supplemental oxygen, vaccination against pathogens causing respiratory infections, for example, pneumococci. Now about interstitial lung diseases, ILD. Interstitial lung diseases, ILDs, is a term encompassing a heterogeneous group of disorders characterized by inflammation and progressive fibrosis of the lungs. Cough and progressive exertional dyspnea are the most common symptoms. Idiopathic interstitial pneumonias, IIPS, a group of interstitial lung diseases of unknown disease, also described as diffuse parenchymal lung diseases, DPLDS, characterized by inflammation and fibrosis of the pulmonary interstitium, but frequently also affect the air spaces, peripheral airways, and vessels. And pneumoconiosis, a group of restrictive interstitial lung diseases caused by the inhalation of certain substances, mainly dusts, that often affects miners and agriculture workers. Now, idiopathic interstitial pneumonias, idiopathic pulmonary fibrosis, IPF, and other IIPs, or idiopathic interstitial pneumonias, like acute interstitial pneumonia, cryptogenic organizing pneumonia, respiratory bronchiolitis associated interstitial lung disease, desquamative interstitial pneumonia, non-specific interstitial pneumonia, lymphocytic interstitial pneumonia, and idiopathic pleuroparenchymal fibroelastosis. About IPF, definition of IPF is most common type of ILD characterized by irreversible pulmonary fibrosis and impaired pulmonary function. Incidence is 10 per 100,000 cases per year. Affects mostly men from 50 till 70 years of age. Requires the absence of other known causes of interstitial lung diseases, for example, medication, environmental exposures, connective tissue disease. Presence of usual interstitial pneumonia, UIP pattern on high-resolution CT scan or histopathological studies. And we have on CT scan honeycomb appearance with or without traction bronchiectasis, ground glass opacification with superposed reticular abnormalities, and bibasal subpleural distribution. The prognosis of IPF is very poor. Respiratory failure usually occurs within 3 to 7 years. About acute interstitial pneumonia, a rare, severe type of idiopathic interstitial lung disease with an acute onset that can progress rapidly to respiratory failure. Usually affects individuals without a pre-existing lung condition. Manifestations include rapidly progressive dyspnea, fever, and cough. Imaging findings include bilateral ground glass opacities, traction bronchiectasis, and consolidation areas. About cryptogenic organizing pneumonia, COP. This is a rare type of ILD characterized by inflammation of the bronchioles, alveolar ducts, and alveolar walls. Incidence is 1 to 3 patients per 100,000 hospital admissions, and affects mostly individuals from 40 to 50 years of age. Histologically characterized by the presence of Masson bodies, granulation tissue buds made of foamy macrophages, mononuclear cells, and fibrous tissue, and chronic patchy interstitial inflammation without fibrosis. Non-specific interstitial pneumonia, NSIP. This is a type of ILD characterized by mild to moderate chronic interstitial inflammation without specific histopathologic findings that characterize UEP, usual interstitial pneumonia. Affects non-smoker women from 50 to 60 years of age, associated with connective tissue diseases, for example, systemic sclerosis, HIV infection, and hypersensitivity pneumonitis. How can we diagnose this disease? Immediate subpleural sparing on imaging studies is considered specific for NSIP. And histological findings include interstitial thickening due to fibrosis and or inflammatory cells. Desquamative interstitial pneumonia. It's a rare type of ILD characterized by lung inflammation due to intraalveolar mononuclear infiltration. Affects men from 40 to 50 years of age with a history of smoking. Imaging studies show ground glass opacities in the lower pulmonary lobes, usually without peripheral reticular opacities. Histologically characterized by intraalveolar accumulation of macrophages and thickening of alveolar septa. Respiratory bronchiolitis, interstitial lung disease. It's a rare, mild ILD characterized by bronchiolar inflammation. Affects individuals from 30 to 50 years of age with a history of smoking. Histologically characterized by accumulation of brown pigmented macrophages and bronchiolar submucosal inflammation. Lymphocytic interstitial pneumonia is a rare ILD characterized by lymphocytic infiltration of the alveolar and alveolar septa. Affects adults, especially women of all ages, associated with autoimmune disorders, lymphoproliferative disorders, and HIV infection. histologically characterized by diffuse alveolar and interstitial infiltration with plasma cells and polyclonal lymphocytes. Idiopathic pleuroparenchymal fibroelastosis is a rare ILD characterized by pleural and subpleural fibrosis. Affects non-smoker individuals between 50 to 70 years of age. Imaging studies show pleural and subpleural thickening of the upper pulmonary lobes on imaging studies. Histological findings include intraalveolar fibrosis and elastosis of the alveolar walls. Now, interstitial lung diseases, pathogenesis. Generally, all types of ILDs share the same basic pathophysiology. Repeated cycles of tissue injury in the lung parenchyma with aberrant wound healing, altered collagenous fibrosis, and at last remodeling of the pulmonary interstitium. Pneumoconiosis, inhalation of dust particles, phagocytosis by alveolar macrophages, destruction of alveolar macrophages, inflammatory reaction, and at last scarring, granuloma formation, as in previous cases. Interstitial lung diseases, clinical features. We have progressive dyspnea. First of all, exertional dyspnea that progresses to dyspnea at rest. Patients may present with high-frequency, shallow breathing to compensate for dyspnea. Persistent, non-productive cough, bibasilar inspiratory crackles or rales, Velcro-like rales on auscultation, fatigue. Fever is common in hypersensitivity pneumonitis and sarcoidosis, but otherwise uncommon. Findings suggestive of connective tissue disease, sarcoidosis, or vasculitis. Advanced disease. In advanced disease, we have digital clubbing due to chronic hypoxia, cyanosis, loud inspiratory wheeze. And now about diagnosis. Due to the wide variety of subtypes and symptoms, there is no universal diagnostic algorithm. Complete medical history, physical examination, serology, imaging, for example, chest X-ray, CT scan, and pulmonary function test should be performed in all patients with symptoms of ILD. Lavage and biopsy can help identify confounding conditions like infection, malignancy, and confirm the diagnosis of a given type of stage of ILD. We need for diagnosis complete medical history, age and sex, past medical history, like underlying conditions, medication, smoking history, irradiation history. Also family history, occupational or environmental exposure, like symptoms depend on type, extent, and duration exposure. Now about laboratory tests. We need CBS, complete blood count, LFTs, BUN and creatinine, arterial blood samples, elevated alveolar arterial. In arterial blood samples, we have elevated alveolar arterial partial pressure of oxygen gradient and decreased partial pressure of oxygen. A screen for rheumatic and autoimmune diseases, for example, rheumatoid factor, ANA, aldolase, anti-CCP, anti-GO1. In case of suspected pulmonary hypertension or carpulmonale, we have BNP or NT-proBNP. Imaging, it's important. Chest X-ray is normal in approximately 10% of patients. Increasing reticular opacity, sign of fibrosis. Patients may have nodular or mixed patterns, ground glass opacities. Now about CT or high-resolution CT scan. The most common symptom is honeycombing, multiplied cystic lesions with the lung parenchyma due to fibrosis, traction bronchiectasis, irreversible dilation of the bronchi and bronchioles due to fibrosis, irregular thickening of the interlobular septa, smooth, nodular, or irregular. Specific patterns for ILDs may be specific for the underlying condition. For example, hilar lymphadenopathy with or without bilateral reticular opacities in sarcoidosis, pleural plaques, and pleural reticulonodular opacities in asbestosis. Here you can see we have X-ray, also CT scan. Pulmonary function tests by spirometry, lung volumes, and diffusing capacity. Spirometry, also body plethysmography and DLCO. Restrictive lung disease pattern is when reduced lung volume normal, decreased FEV1, decreased FEVC, and increased normal FEV-FVC ratio. We have in case of interstitial lung diseases decreased diffusing capacity for CO, DLCO, highly sensitive parameter. Sometimes we need to perform bronchoscopy to obtain bronchoalveolar lavage, and we have in bronchoalveolar lavage we perform in patients with acute and rapidly progressive respiratory symptoms, with hemoptysis, infection, patients with sarcoidosis, hypersensitivity, pneumonias, IPF, idiopathic pulmonary fibrosis, or Langerhans cell histiocytosis. Less invasive procedure than a lung biopsy. The bronchoalveolar lavage is more and less invasive procedure than a lung biopsy, and information is the same, informative. And at last, surgical biopsy. Indications for biopsy is inconclusive initial evaluation, atypical or rapidly progressive symptoms, disease exacerbation, ambiguous pulmonary function tests. In patients with minimal signs or symptoms and stable disease, close observation, for example, PFTs, high resolution CT scans over several months may be sufficient. And additional tests like electrocardiograph and echocardiogram in case of suspected pulmonary hypertension or concomitant heart disease. And about treatment. First of all, smoking cessation, supportive care, oxygen therapy, pulmonary rehabilitation, vaccination against influenza and pneumococcal vaccines. Antibiotics if bacterial interstitial pneumonia is suspected. Lung transplantation indicated in end stage of ILDs, only definitive treatment. Further general measures not applicable to IPF. Avoid or limit exposure to causative or exacerbating substances, like cessation of therapy with causative medication contain occupational environmental exposure, example, with protective equipment. Bronchodilators, corticosteroids, in case of hypersensitivity pneumonitis. Immune modulators, for example, azathioprine and mycophenolate. And last slide we have regarding treatment of interstitial lung diseases. Antifibrotic agents, it's most important treatment. Pirfenidone, an antifibrotic agent that inhibits TGF beta-stimulated collagen synthesis, decreases the extracellular matrix accumulation, and blocks PDFG effects in vitro. And nintedanib, an intracellular inhibitor of tyrosine kinases that target fibrogenic growth factors. For example, vascular endothelial growth factor receptor, fibroblast growth factor receptor, and platelet-derived growth factor receptor appear to slow disease progression in IPF. These two agents, pirfenidone and nintedanib. Prevention of gastroesophageal reflux is important to manage. Other idiopathic interstitial pneumonia therapy varies by subtype and corticosteroid and immune modulators are helpful in this case. And thank you for your attention.